This week on the BackTable podcast.
There are newer trials looking at asking that exact same question. Now that we can avoid the normal structures, can we just do this faster? For gynecologic cancers, I feel like this is going to be the future. This has already changed how we give prostate cancer radiation. Before, it used to be 40 sessions of radiation. Then a very standard way to do it is in 20 sessions because our technology improved and we had the same toxicity and the same outcomes. And then even now, we've moved it up to 5 sessions. And now that's even part of the NCCN guidelines. So with more advanced technology, we can give higher doses, safer, and with equal efficacy. I hope that will be the future for gynecologic cancers as well.
I'm Mona Guo with my co-host Marcia Ciccone, and we are here with Andrew Lim, who is one of our radiation oncologists at USC. And we are going to talk today about understanding the modern radiation techniques, indications for definitive adjuvant therapy, go over a little bit of common toxicities and how we can manage and what we would see both as GYN oncologists as well as general gynecologists or oncologists after we send them to our radiation colleagues. Dr. Ciccone, do you want to give a little background for Dr. Lim? We'll introduce him.
Sure. So we've known Dr. Lim basically since he's been here at USC. It's been a great time interacting with him. Dr. Lim is Dr. Guo's fellow Canadian. So he graduated from medical school at the University of Western Ontario and then did residency in Radonc, also at the University of Alberta. He completed his brachytherapy fellowship at UCLA. Fortunately for us, he now works at Keck and Norris, and he's our director of brachytherapy. So Dr. Lim routinely treats prostate cancer, gynecologic cancer, sarcomas, skin cancer, and metastatic cancers. And just on a personal and professional level, Dr. Lim does a great job treating our patients. Our patients love him. And he's a person who thinks outside the box, definitely thinks critically about our patients and about how to best treat them. And so we are very, very fortunate and very pleased to have you with us today, Dr. Lim.
Yeah, thanks for having me.
So we'll jump right into it because I remember in medical school and residency seeing those pictures of, 4-field box radiation where people just get zapped from, or I guess not even 4-field, just front and back, just get zapped straight on for radiation. But I guess what are the newer techniques in radiation now?
Well, ultimately, over the last 10 years, our technology has advanced tremendously. Okay. Before, exactly, you're right. We just had one machine shooting one direction, and we just do a box in the general area. And that's back before really computers. But since then, our technology has advanced tremendously. Instead of just shooting one block, we can now actually precisely sculpt where we want the radiation to go in the body and where we want it to miss or minimize dose. And it's really changed a lot regarding one, toxicity. Our ability to avoid critical structures has definitely gone down over time, as well as we're able to elevate the amount of dose that is able to go to cancers to improve our control rates. Specifically for gynecologic cancers, we've run multiple trials, one's RTOG 1203, the next is Parser, looking at what are the toxicities compared from 4-field box to IMRT, which is a more sculpted. And both acute GI toxicities have improved as well as long-term late GI toxicities because we can avoid that intestine. And that's actually in the external beam world where we're able to sculpt the dose. But actually, for cervix cancer in particular, we also do brachytherapy. And we are much better able to sculpt the dose now compared to before.
I mean, you mentioned just external, we're just going to go a little basic here. External beam, IMRT, are those the same thing?
Yeah, good. Very good question. Yeah, there's a lot of different terms in radiation oncology. So external radiation, it's ultimately, where the patient just lays down on a table and this big machine rotates around the patient, doesn't touch the patient, and it basically shoots radiation from many different angles, and it all gets focused in on the cancer. So that's external radiation. The four-field box is a form of external radiation where it actually just like treats from 4 different angles, front and back, left and right. But IMRT, it actually shoots from many different angles with many different intensities. IMRT stands for intensity modulated radiotherapy. It actually has many different names, but it's the one that we can use to sculpt the radiation dose the most.
So how does that work compared to like what a radiation oncologist job was when you had the 4-field box and I guess there wasn't a whole lot of treatment planning that went into that. But how does that work for you? Like when you get a patient and you look at their imaging and you get this CT of where exactly the tumor is, what do you then do to kind of map out where they should get the radiation, what areas should be avoided, and how does that work?
This is maybe even before my time in some sense, but before, back in like the 4-field box era, they used to just use bony anatomy to try to figure out, hey, where would the cervix be with respect to the femurs on a plain x-ray, right? But nowadays, we do a CT scan, and then we literally go on that CT scan, and we can see the cervix, and we literally draw it. And then we have to know about how do these tumors typically spread? What are the channels of patterns of spread? And then we basically draw the lymphatic channels from the cervix to the parametria, to the obturator's internal, external, common iliacs. So it's all that us drawing on that CT scan that has changed. And then we also draw the normal structures, what we want to avoid. And so a lot of extra time is going into designing that. And then actually even furthermore, more recently, we also implement actually AI in designing this. So our AI algorithms have the first go at the drawing all this. And only now do I like review what the AI has done and then make necessary changes where it's messed up. But we make those changes so that each time is perfect. We also have somebody called a dosimetrist, and they work on our drawings, and basically they understand the machine and how the machine gives radiation, and they try to make it so that the radiation goes to where we draw it and avoids what we want to miss. So there's a whole lot of stuff that goes on in the background before we even begin the radiation in the planning process.
Does this happen every time you see the patient? Because like radiation, they're coming to you every day.
The designing of the plan typically happens once before we begin the treatment. And then every single day they get the radiation. I'll walk you through their typical day, just so you understand. So they're here for about 40 minutes, and most of the time it's just waiting around. And then when it does come time for them to get treatment, they just lay down on the table. They're going to be on that table for 15 minutes, okay? But for the first 7 minutes, the big machine spins around them. It actually does a mini CT scan of the area in question. And it actually verifies that the tumor is in the right position. And if it's not, the table actually moves and rotates to put the tumor in the right position. And only once we are certain that tumor is exactly where it needs to be, then the machine spins around it and actually implements that plan we made on the first day. And that's only 7 more minutes. So they spend 15 minutes on the table, then get up and go home.
That's crazy. I actually did not realize that that's exactly how the patient was positioned and how you make sure that the dose goes to the correct spot, which makes sense because if you made this detailed plan, you got to get the accuracy has to be perfect, you know?
Yeah, patient gets their own like little bodysuit, right? I think I've seen these. I don't know if our gyn patients do, but definitely for like your head and neck cancers or something, you get these like molded, personalized things that you lie on.
Oh, absolutely. And that's to make sure they don't move during the treatment and also to try to replicate what we did at that CT simulation day, the very first day. Yeah.
Can they take those home? I would want to take it home.
Yeah, we give the masks to
Yeah.
everyone who wants them. Yeah. And some people turn it into like a
Oh.
flower bin.
Yeah.
So do they
that's
still
really
need to
nice.
get those tattoos? Because we always do have little radiation tattoos that I always thought were for positioning them. Does that still need to happen when you have that technology?
The answer is we are fading away from doing tattoos. Nowadays, we have something called, the brand name is called Vision RT. And basically, to first put the patient in like generally the right area, we use surface topography. We look at the surface topography of the patient versus the CT scan and kind of range them in the right position. And then that's generally to get them in the right area. Whereas before we used the tattoos to generally get them in the right area. And then we do the cone beam. So less and less we are using the tattoos. And when I say tattoos, they are really just like a freckle. We are less and less needing that. Yeah.
I didn't know that either. That we're learning things already. Like we send so many people to you guys. I mean, again, cervical cancer, I think, is the most common disease site where we collaborate and work together, just because chemoradiation is curative for our locally advanced patients. I think we can spend a whole podcast just talking about radiation and cervical cancer. We're trying to keep things general here, and the next time we have you come back, we can talk more in detail about all these new studies. But I think part of me, when I have to explain radiation to my patients, they're often like shocked that it has to be 5 weeks. Like 5 weeks every single day, they have to come in and get radiation. And it's a lot. It's, even though it's only, we said 45 minutes every day, it's still, going into the hospital, potentially paying for parking, all of these things every single day. Why can't it just be done in like a week?
It all has to do with the normal structures around it and not overdosing the normal things. I'll tell you that historically, like back when we did the 4-fill boxes, we couldn't do it any faster. If we tried to give the same dose in 5 sessions, it would damage the normal structures too much. And so they had to go slow to protect the normal structures. And then our technology is getting better and better. And so we are avoiding the normal structures. But still, based off the old data, we're still doing it fairly slowly. But there are newer trials looking at, hey, asking that exact same question. Hey, now that we can avoid the normal structures, can we just do this faster? And this, for gynecologic cancers, I feel like this is going to be the future. This has already changed how we give prostate cancer radiation. Before, it used to be 40 sessions of radiation. Then a very standard way to do it is in 20 sessions because our technology improved and we have the same toxicity and the same outcomes. And then even now, we've moved it up to 5 sessions. And now that's even part of the NCCN guidelines. So with more advanced technology, we can give higher doses, safer, and with equal efficacy. I hope that will be the future for gynecologic cancers as well.
So I know, when we talk about how many times they need to come for radiation, right? That depends on the way you fractionate it and the way you divide it up. But the total dose that they need to have is the thing that you're trying to achieve. And I think that has stayed the same, even though the technique has changed. So how do you make sure that that dose gets reached? And then out of curiosity, separate question, how does that dose compare? Because you just talked about how for prostate cancer, we can decrease, the number of days that it takes. Do they have to get as high doses in prostate cancer as we give in cervical cancer?
Yeah. Generally, prostates get about just to the prostate itself, is getting about 80 gray. If we're to do 2 gray per fraction increments, the standard is typically 80 gray. And then with cervix cancer, we're really trying to get above 85, really 90, 95. So it's in generally the same area. And the reason why prostate cancer, though, has been able to move to 5 fractions is because for most prostate cancers, it doesn't typically spread to lymph nodes, and we're not typically treating the lymph nodes. Or for most of them, for, of course, high risk, definitely does. And we have to change what we do to 25 sessions in that scenario. But it's because we're just treating one small area. If for cervix cancer, it was the same. It just stayed typically stayed in the cervix until it became very advanced. We could probably just do brachytherapy or an SBRT. But because we're having, with cervix cancer, always having to treat larger and larger areas, it spread up to the perioretics. That's probably why it hasn't changed so quickly. And just so you know, like for a couple of trials, endometrial cancer are now looking at a 5-fraction regimen for endometrial cancer instead of 25 standard, with slightly different toxicity profiles. And we're still waiting for the long-term efficacy or cancer efficacy rates.
Going into endometrial cancer here, we usually see, yes, for external beam, but then it's the brachytherapy, which you alluded to earlier, with endometrial cancer and then with cervical cancer. I mean, the brachytherapy, I think, is used for different indications in both of these diseases because it's different time in their treatment course. That's your specialty, and we don't have enough brachytherapists in the country. So I feel like it's such an integral part in getting that high dose of radiation to the cervical tumor itself. Can you just talk a little bit more about your techniques for brachy, but then also like what happens if you don't have brachy? Like what does that mean for the patient if you can't end up getting that brachy?
For like a locally advanced cervix cancer, you don't get the brachytherapy. I think that it's been shown again and again that there's a much higher local recurrence rate, and it will come back in typically the cervix area. That's why we needed that extra dose there. But yeah, let me tell you a little bit about how like brachytherapy has kind of changed through time. Before, we didn't have really good imaging, and a lot of patients, no matter what the size, would get tandem and ovoids or tandem in a ring. And with the tandem in a ring or ovoids, we really have limited ability to shape the radiation, to sculpt the radiation. This is kind of like, this is a one shape of radiation we have, and we'll use it for everyone, no matter what size of the tumor, if the tumor is invading more into the perimeter or anything. But nowadays, we have interstitial brachytherapy and image-guided brachytherapy. That allows us to sculpt the high-dose radiation a lot better than a standard tandem and ovoid. And so this has really changed the way in which we do brachytherapy for cervix cancer. So let me describe kind of what happens. Let's say somebody has cervix cancer and the disease extends all the way along the left perimetria. Sure, we can put in a tandem and ovoid, but that will only cover the central cervix. Then what we do is we do the interstitial component. We use ultrasound guidance to put these needles, typically through the perineum or through the upper vagina, directly into the tumor. And that allows us to sculpt the dose laterally while sparing the rectum and the bladder. That ultrasound-guided catheter placement and then the ability to sculpt the dose laterally has allowed us to treat the entire tumor, improving cure rates, as well as, in the same time, minimizing toxicity by minimizing the amount of radiation going to the bladder and the rectum.
I assume anesthesia when this happens.
Anesthesia is, I think, the most important thing for the patient. And I would never do this without anesthesia.
But it's all outpatient now still. Because in residency, we were still doing, I think we were like one of the last places to still be doing low-dose radiation, low-dose brachytherapy. So we had to admit our patients afterwards with these huge appliances. And then they were all like sequestered away in this one corner of the hospital with these, people put tables up to try to block the radiation.
Yeah.
And we had to round on them every day.
Good point. So with low-dose radiation, there'd be literally somebody like loading little radioactive beads within each of these needles. And then everyone would get exposed to a lot more radiation. And then furthermore, it's a lot less precise. And nowadays, we have HDR radiation, high dose rate radiation, where we actually have a robot. First off, just so you know, we do a CT scan with all this in place and an MRI. And we design the radiation in a computer software, and we decide where we want the radiation to go in the computer world. And then once we're happy with how the cloud of radiation is going, then we actually send the data to the robot. And then actually the robot does it, implements it. So no person's touching this. There's less radiation exposure to members in the hospital, but a robot will send that radioactive bead in, and they'll sit within the needle for like 5 seconds, 10 seconds here, executing this radiation plan. And then the robot actually removes the radioactive bead and puts it deep within itself so that there's no more radiation in the room. And then we simply just take all the tubes out, and the patient stands up and they go home. The way that we do it is like a day procedure. That being said, in some situations, we keep people overnight for 1 night or 2 nights, depending on their cancer scenario. But typically it's a day procedure.
How long does it actually take, to deliver the radiation?
So the actual delivery of the radiation can vary depending on how big the tumor is, but oftentimes it's only 5 to 10 minutes. So a lot of work for just 5 to 10 minutes, but necessary work. And then to actually place the apparatus and the needles depends on the tumor and patient anatomy. If it's more simple and requires just a tandem and ovoid, it could be as quick as 20 minutes or 15 minutes. But if the disease is more extensive, requiring more ultrasound guided catheter placements, then it can take up to an hour.
We just talked about IMRT and how that is already designed to avoid other structures or to avoid adjacent structures that we don't want to radiate. So is it possible to achieve the same level of radiation to the tumor with just IMRT, or do you need brachytherapy, and why?
The cervix, it's on the parametra, and overall it's fairly mobile. And so even during the course of radiation, it can move around. That makes it very difficult for the external beam approach to just target the cervix if it's kind of moving as the bladder's filling or the rectum's contracting. And that can make it dangerous to the bladder or the rectum. And there's actually multiple studies looking at external beam boost versus brachy boost in cervix cancer. And every time the external beam just doesn't quite give enough, and there's higher recurrence rates. Whereas with brachytherapy, the needles are directly in the tumor, so we're treating it from inside out. And so we don't actually have to worry too much about the movement of the cervix because the needles will move with it. Ultimately, that's why we still use brachytherapy, because it can spare the normal tissues better because it can move with the cervix. Studies have shown that the brachytherapy boost provides better control compared to external beam boosts.
So if I were a patient listening to this, I don't know how many patients do, asking for making sure that your plan includes brachytherapy if you have cervical cancer is really important, and to really advocate for yourself to try to get that.
And to make sure you have somebody who's experienced in doing this, because not every radiation oncologist is able to do these techniques, correct?
Correct, yeah. You need definitely extra training, to do the ultrasound guided procedure.
It can make it a little hard for patients who maybe don't have access. I mean, it's always good to be in a metropolitan area. You tend to have more access, but there are patients even in our country, I think, who may have trouble accessing, a radiation oncologist who's qualified to do this kind of treatment, or may have to drive really far in order to find somebody.
And another part is just getting it all done within that, I think, 8 weeks, right? Making sure that there isn't a delay of completing it. Or what the number is every day you get above 1% decrease in survival.
Oh yeah. Basically, we want all the radiation to be done within 7 to 8 weeks. And the reason is, between each radiation fraction, the cancer can grow. They could be accelerated repopulation. And so it's been shown time and time again, you have to complete the whole package within 7 to 8 weeks. Yeah.
Have you found ways to help patients through those 5 weeks? What do you recommend that someone does so that, they can help with the side effects, with the fatigue, for all of this. Because we usually don't see them during those 5 weeks when they're getting radiation. They come for like weekly cisplatin or carboplatin usually, but sometimes, like often we're not seeing our patients. They're just coming into the infusion center. And then you see them at the end of this and they're like, that was brutal. So I guess how can we better prepare them, or like, what do you do? What do you recommend?
Yeah. Personally, I think the first best way to help a patient through it is to let them know and literally even just draw them out the entire plan and what to expect. So mentally, they're understanding of, okay, this is the next step. This is the next step. And telling them like the typical side effects through external radiation, including like some fatigue, as well as eventually they're going to develop some level of diarrhea, in which we'll give them Imodium or lower dose psyllium fiber, and just like letting them know each step. And then also just letting them understand the whole process of brachytherapy, because a lot of times I find that it's the uncertainty that really elevates their anxieties and fears, and just through direct education, that alone will bring them to a lower stress level.
That preparation part of it is so important. And especially for our young patients with cervical cancer, I try to warn them that at some point you're going to probably go into radiation-induced menopause, and to really let us know when that happens. I don't think I've ever looked this up. I don't know if you know, when does that tend to happen? Like during that external beam? Like when do you usually see people start complaining of hot flashes?
Generally, like a couple weeks in. Like if the ovaries are in the pelvis and they're getting like 45 gray, 2-3 weeks into radiation, they start reporting like a little bit intermittent hot flashes. Because ovaries, the part that produces estrogen, is pretty radiosensitive.
Do you ever prescribe them hormone replacement? Do you think most radiation oncologists are remembering to talk to their patients about that?
I mean, the treatment of cervix cancer is definitely a team sport, right? With our wonderful gynocs, who I'd have to say know a whole lot more about the pros and cons and methods of hormone replacement therapy as well as chemotherapy. And so I think it's very important to have a great team, which I'm very fortunate to have, to further discuss and prescribe the hormone replacement therapy. But I definitely do tell every single patient that they're going to go through menopause and they will no longer be able to have children. And if they have to get oocyte preservation, like before is the time.
Mm-hmm. Do you find that the medical oncologists are counseling? Because I know sometimes these patients don't even see a GYN oncologist. They see a medical oncologist who gives them chemo and then sends them to radiation. And sometimes, I know you see those patients too, because you'll send them over to us for whatever reason, whatever complication may happen afterwards. We hear about them. But do you find that they're doing an adequate job counseling and helping patients with kind of GYN-related things, maybe fertility-related issues in these patients who are often premenopausal?
Fertility-wise, yes, because they definitely see other patients who are young. But from the hormone perspective, I'd have to say this is really where our gynocs, this is where they shine and why we need them involved as well.
And for our general GYN colleagues out there too, give these patients hormones. It's not going to affect their cancer-related outcomes. If anything, it's going to improve things because they're going to be less fatigued and have less of the menopausal side effects that hopefully will allow them to continue on with therapy. Not to mention the rest of the cardiac and bone benefits for these patients who have really premature menopause at in their 30s or 40s.
Yeah, definitely hard enough to have cancer and then have menopause on top of that is real tough.
Yeah, you don't really expect it or think that that's something that you would have to, you don't think, I don't know. Personally, I feel like if I was about to be treated for cancer, I wouldn't think immediately what is my hormone status? What's my sex life going to be? Of those things, which for cervical cancer, the treatment really affects all of that. Your sense of womanhood, your relationship with your partner. There's so much that goes into the post-treatment recovery.
Yeah, definitely emotional and physical changes that are all drastic that these women go through. that definitely affect their sex life and their feeling about womanhood, you know?
I actually have learned to directly address this. I mean, you saw the photo, brachytherapy looks very extreme in a very sensitive area. And I've found that a lot of patients are very concerned about anything and get really anxious about anything in that area again. And I directly address with them that, their feelings are from our treatment, like what we had to do, and nothing to do with them. And I really recommend that these patients go to a pelvic floor specialist to start, and also use the vaginal dilator for stenosis reasons, to start getting comfortable with things down there.
You do give them dilators. I'm sure most patients who are coming from after they've seen you have dilators that they've been taught how to use. And I feel like that doesn't happen all the time for previously with, treatment in other places. I feel like it's sometimes just overlooked. But yeah, I do really appreciate that. I'm sure the patients appreciate that the direct, addressing this is not something to be ashamed about bringing up. This is nothing about vanity or anything. This is just about your health. And aside from, I think, sexual activity, it makes our exams much easier afterwards. It's less painful, just from a cancer surveillance standpoint. And then vaginal estrogen.
Yeah, definitely. I think there is a huge importance of vaginal dilators, and a lot of times patients aren't even told that your vagina could literally close up as a result of this radiation, Sometimes they'll show you, just like Dr. Guo said, they'll show up in your office and you're like, did you get a dilator? And they're like, nope. What dilator? What is that for? So I think, I agree. They do not come from you saying that to me. So
I'll give you my 2 cents on this unfortunately as a man, but I found that, the standard practice is to tell women how to use a vaginal dilator by laying down on the bed and putting it in them for 15 minutes. My old boss, I guess she had to use one, and she just couldn't take that amount of time out of her day. And then she also questioned, why does it have to be in there for 15 minutes? What's it doing for most of that time? And so what worked for her was she just keep in the shower, put it in for 15 seconds, move it around, and then take it out and go on with life. And I think it's more consistency. Will they actually use it? And I think it's a lot easier to do that versus 15 minutes.
Yeah, I think it's frequency more than duration. I don't know that duration is gonna matter. I think you're right about that. That makes sense. I mean, also, if they are sexually active, I tell them too, having sex regularly is going to help, if they are comfortable doing that and they're feeling like doing that.
I mean, we've all seen talking about radiation side effects, the long-term complications. I mean, we have short-term complications. You kind of mentioned a couple of them when we were the diarrhea, where you're giving fiber, or dysuria. But this gift that keeps on giving with radiation. How do you prepare people, or what do you tell them that what they could expect in the long term after you stop seeing them? What side effects could pop up?
Oh, yeah. I mean, we definitely mentioned one, the vaginal stenosis long term. And then, there's pelvic bones all around that area. And we do know that radiation can just slightly weaken that, especially with no estrogen. So, they have to keep up with bone health, weight-bearing exercises, calcium and vitamin D. Those are the typical common side effects. But I mean, we also describe other side effects that are rarer, and we definitely don't understand who's going to get it, who's not going to get it, but cystitis or proctitis. And there are treatments for both of those. With proctitis, it could be Proctofoam, or if there's bleeding, argon laser, coagulation, or even hyperbaric oxygen. Because ultimately, actually, I think most radiation side effects are derived from the tissue turning more into a scar type tissue. And then with that, there's less vasculature. So there's a lot of hypoxia, and because of lack of vasculature and scar tissue. And so that's how you can get non-healing ulcers. So getting more oxygen, hyperbaric oxygen to the area helps.
Are there any risk factors going into radiation since we're looking at, oxygenation effects, how effective the radiation is, are there any risk factors pre-existing, like medical conditions or like body habitus that affects the likelihood of developing these like longer term complications, or things like retroperitoneal fibrosis when people start having like ureteral obstruction and things like that? Is there anything that you think puts patients at higher risk of developing those complications?
So we know that there are some hereditary genetic mutations like telangiectasia, as well as, yes, correct, as well as like double-strand DNA repair genetic issues.
So like BRCA patients?
But there's actually not. That is not, because we treat breast cancer, BRCA, everything. They do not have an issue, interestingly. But there's so much we don't know about who is more sensitive to radiation. And I wish I knew. I wish we had better abilities to say who's at more prone for toxicity. Because I literally give the same I could give the same radiation to two different people, and they have two different long-term toxicities. And then, interestingly, there is obviously, we're trying to figure this out, right? And in the prostate cancer world, there's actually a blood test that can look at the person's genetics and give you kind of a sense of who's going to be more likely to develop prostate radiation side effects or not. Yeah. And this only exists in the prostate world.
Man,
at this point in time.
You're getting this male research is way ahead of female research. We're seeing that again.
I mean, I think I agree. And it's partially because prostate cancer is way more common.
True.
What is that test?
Prostox, PROSTOX.
How can we validate that for women? Like, I wonder what exactly they're looking at genetically, and if it correlates, or if or if it would also work for women.
I don't see why not. Yeah. The only issue is, this is used in prostate cancer where patients have options, right? Where it's like, oh, you could get surgery or you can get radiation. And so it can be a deciding factor. Unfortunately, with cervix cancer, it more has to do with what stage you're at, and you don't really have that many options.
Yeah, it's like you're getting this radiation regardless if you want to live, basically, right?
Exactly. Yeah.
Yeah. It's tough.
Yeah. And so there's so much we don't know, and I would love to be able to tell people their exact risk probability of developing side effects. It's just we don't have all the information yet. We're getting closer.
So many research opportunities.
I know, I'm discovering things that we should do.
I think the radiation oncologist who was here before you was trying to do a trial on like a spacer filler between injecting I don't even know what they're called, injecting something in the rectal vaginal space to help to increase that diameter or the distance from the source, or to move the rectum away from the source to decrease side effects. And I think it was used or is used in prostate cancer or had been trialed in it, but we just couldn't get it off the ground here for cervical cancer. Like the sponsor was, I think, not really interested because there's not many patients, and it's, yeah.
There's a couple of companies called Barrigel or Space OAR.
Oh, so you do use it?
Oh yeah. We put a needle, put gel in between the prostate and the rectum, and separate it. And that gel is hyaluronic acid. And it's the same stuff that women use in or men use in their lips. And it just dissolves away in 3 months. And yeah, there definitely are some studies looking at trying to use this in Gynecologic to separate the vagina from the cervix to try to get it out of the way. I mean, the difficulty is that the cul-de-sac is there, and you probably don't want to be injecting this into the peritoneal cavity. Not that it'll do very much harm, but it probably just won't do that much good.
It's not going to stay if you inject it in the peritoneal cavity. Yeah. It's just going to be free floating. So you'd have to get it in like the rectovaginal septum and then have it kind of like blow up that. And I don't know how well that would work. Yeah, it's a very tiny space.
Yeah, there's natural barriers that it just like make it a little bit harder to achieve that goal.
We won't know until we study it
Sure, we
or
don't
try
know.
it.
I've done it once.
In women?
Yeah.
Wow.
For extreme situation.
I had a patient that I asked you about pretty recently who I saw back the other day, but she was recommended to get brachytherapy for endometrial cancer, and she was very concerned about her rectocele and how the radiation would affect her rectocele. And so, just thinking about things like spacers and, when you have a patient who has prolapse, either, bladder prolapse or rectal prolapse, does that change the way you give radiation or the way you do brachytherapy?
Yeah. I mean, as the anatomy changes, you have to adapt. With regards to brachytherapy, the radiation's only in there for 10 minutes. So you just have to make sure that that rectocele has been reduced with vaginal packing or something for those 10 minutes. That's ultimately what happens. We do the exam, we put in the tandem, the interstitials, all under ultrasound guidance, obviously avoiding the rectum as well as the bladder or cystoceles. And then we pack it kind of like a pessary is what they call it. And then we do a CT scan, and it's basically all reduced for those 10 minutes or for the time we do brachytherapy. And then when we take everything out, it'll go back to its normal state. I hope that the increased fibrosis from the radiation improves that, but I wouldn't bet on it.
So I guess I'll ask the question, if somebody has cancer recurrence and they've been radiated before, what's the deal? Can we radiate them again? How much more radiation can you give if somebody's had the whole pelvis and brachytherapy?
Yeah, the question of reirradiation comes up all the time. And there's a couple different factors that we consider, right? We first consider, how much radiation was given at the index time. What's the time period between where the patient would have time to heal? And then how much radiation are we going to give again? And so if the first time they had a lower dose or palliative intent radiation, and a year passed or something like that, then we have no problem giving radiation again. And there's actually multiple studies looking at that and trying to figure out what's the right timeline and everything. And there's nothing set in stone. So if you talk to multiple different radiation oncologists, you'll probably hear multiple different answers. But really, these are the factors that we consider before a reirradiation.
When we get radiation summaries from another radiation oncologist, is it pretty straightforward? Does everyone do things in basically the same way and write things the same way? Or do you actually have to see their plans?
I think you have to see personally, I mean, they can write a very detailed paper report, but it's not until you actually see the sculpture that they made that you can actually understand where the radiation went. Yeah. A picture's worth 1,000 words, essentially.
Were you an artist? Are you an artist?
I like to think of myself as an artist.
Yeah.
But
you're doing this with a mouse or with a pen, a stylus?
I personally use a mouse, but many people use a stylus. And then remind you now, we just have AI do it. We do a lot of it. But really, the hard part of my job is really decision making when we don't have all the data and making decisions based off the evidence, putting it and applying it to a patient with certain risk factors and everything. That's the hard part. Designing the radiation plan and contouring, it doesn't actually take up that much of my time.
So sometimes we send patients to you because they have a particular symptomatic tumor, whether it's pain, bleeding, obstruction of another organ, like obstruction of the bronchi causing problems in the lungs, neurologic symptoms, or tumors in the CNS. How do you decide what to do for those patients and what treatment? Because sometimes I feel like you guys give them just one day blast of something, and some days sometimes it's three fractions of something. How do you determine what you're going to give them and how it's going to work? Does it depend on what the indication is or the size of the tumor?
I break it down into tumor factors and patient factors because we have a variety of palliative regimens. And I really, look at tumor factors and patient factors and figure out which of those will best fit the situation. For example, if someone is having like severe pain and they're end stage, let's say cervix cancer, and they have severe back pain and the performance status is at like a 3, I'm not going to bring them in for like 10 fractions of radiation. That even coming in to get the radiation is going to decrease their quality of life. And that's ultimately our goal at that time. And so we may give the accepted regimen of like 8 gray and 1 fraction to a bone met to give them effective control for what we anticipate a short period of time if their lifespan's short. And that will maybe be the best thing for them. And we have a discussion about their goals with the patient as well. On the contrary, let's say they have like a spine metastases, and it's a tumor that's painful, and it may be a gynecologic histology that's a little more radio resistant, and we expect them still to live a long time. This is maybe their one site of metastases. In that scenario, we may favor to do like a higher dose SBRT, knowing that there have been some studies showing that this will give them the best pain control for the longest time. They're young and they're healthy. And then also, if this recurs in the spine, it will be a very big problem. And so we should really try to give the highest safe ablative doses. So we really individualize our fractionations based off of patient factors as well as the tumor factors.
Okay, so what is gamma knife? Like, what is that?
So before, maybe 10 years, once again, like 8 to 10 years ago, whenever somebody had brain metastases, it could be 1 brain metastases or 10, they got whole brain radiation. And that means radiation literally goes from left to right, encompassing your entire brain. It would treat the cancers that we could see, as well as the little cancer cells that are probably there that we can't see. And that was the treatment. But as you can imagine, whole brain radiation affects a lot of your normal brain as well. And then 4 months later, 6 months later, patients start to feel some of the effects, decreased cognition. Like ultimately, for somebody who has brain mets, who all their treatment's palliative, we really want to keep as much cognitive function as possible for good quality of life. And so ultimately, we have gamma knife, but ultimately we have a broader thing called a stereotactic radiosurgery, in which we really just treat the one small metastases or medium-sized metastases. And there could literally be 5 or 10 metastases in the brain, and we could treat all of them with high dosages in one session. And the purpose is to avoid the normal brain. We stop the cancer that we can see and avoid the normal brain. And studies have compared whole brain versus stereotactic radiosurgery. And it showed that the stereotactic radiosurgery can preserve your cognitive functioning, with the trade-off that you have to get MRIs every 3 months because you're at really high risk of there being a microscopic cell somewhere else that will need SRS. And then gamma knife is actually just a brand name for a machine that only does stereotactic radiosurgery.
It's a brand.
It's a brand. Yeah, it's a company, a brand name. And so, CyberKnife.
You've done a very good job.
Yeah. CyberKnife is another brand name. It does the same thing with a different machine. And then our variants True Beams, or what a lot of people have that does like pelvic radiation, those can oftentimes do this exact same stereotactic radiosurgery. So, gamma knife is just a brand name, but ultimate that many different machines can do, but it's basically small little shots treating the metastases. And it's typically done in one session. And then if the tumor is small, but if the tumor is larger or closer to the brainstem, they may decide to give it in 3 sessions or 5.
Does everybody have to get that big halo before they get gamma knife?
So with the newest with the newest Gamma knife, oftentimes we don't have to have a halo where they actually drill a frame into your skull to keep your head still. We can do that with the mask. Yeah.
The flower mask. We're back.
Yes, we're back to the flower
Back
mask.
to the beginning.
Yeah.
Wow, that was a nice little whirlwind tour around. I kind of jumped around all over the place with radiation therapy. We didn't even get to the fun stuff. Right? Thank you so much for spending Friday afternoon with us.
Yeah.
No, it is a pleasure to be here. Thank you so much for inviting me.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
See you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.